Hello, and welcome back to another episode of the 2020 podcast, Canada's #1 optometry podcast. I am your host, Dr. Harbir Sayan. Thank you so much for taking the time to join me here, guys, to learn and to grow. I'm very excited. We are at the BC Doctors of Optometry Conference in downtown Vancouver. This is my favorite conference of the entire year. I always look forward to this. We do our board and everybody, all the committees do such an amazing job of putting on this conference. It is the best one, by far, bar none. Everybody says so. I'm bragging. I'm a little biased, but I believe it is. And
I'm from Alberta. Honestly, BCDO has a huge reputation for being notoriously a wonderful celebration, a fun party,
yes,
like great education. So yes, I mean,
you agree. Ultimately,
Alberta's time, right?
Doctor. We'll get back to that.
You'll be out to Banff in October, right?
We have established that the BC Doctors of Optometry Conference is the best conference, even though some might want it to be tied with other conferences. But I am really, really happy to have these two amazing guests with me here. Dr. Sheila Morrison, who is a practitioner optometrist at Mission Eye Care in Calgary. I should know that. I'm sorry.
Where you were a couple months ago.
Yes.
In my backyard.
In your backyard.
Yeah.
Yes. I don't go there often, and I don't stay there for very long. But I apologize. I'm going to stop bashing Calgary. It's not nice. Boo Flames. Okay. Sheila's about to get up and leave now. All right. Sheila Morrison, Dr. Sheila Morrison, contact lens guru, residency trained in contact lenses. They have a residency program at Mission Eye Care, and she is the supervisor of that program.
Faculty supervisor.
One of the.
Dr. Lasby is technically
of course. Dr. Lasby is amazing. Yeah. I'm sorry, I'm like butchering the intro. Listen, Sheila's amazing. I think that's the last thing I want to say about that. We'll get back to you. We'll get back to you in a moment on all the amazing things that you're doing. Next to Dr. Morrison is Dr. Evelyn Lo, Madam President of the BC Doctors of Optometry, newly crowned. Welcome to the podcast, Dr. Evelyn Lo. She is the partner. She's a partner at Mount Pleasant Optometry, and today we're going to be talking about myopia management and the different perspectives from Dr. Lo and Dr. Morrison of how they practice myopia management in their offices. So thank you so much for being here, guys. I appreciate it.
Thanks for the invite.
Before we get into it, I should say big thank you to Hoya Vision Care Canada for sponsoring this podcast. Really appreciate everything Hoya does for optometry and how they have supported the 2020 podcast. All right, guys. So let's dive in. I want to start kind of entry level a little bit, right? So take a little bit of a turn here on how do you practice myopia management at work? Like, what does it look like for each of you in your practices? So start with Evelyn.
So definitely from the moment that the patient walks in, let's say they're a brand new patient, they're going to be screened through from axial length, everything from what their family history is like, and then in the room, after you go through either your cyclo, of course, your regular refraction, and then sitting down with the parents and having that conversation of, well, are you meeting the age norms? And if you're not, then what's your lifestyle like?
Right.
And then making the appropriate recommendations afterwards. I think that's like the most basic and compact. And I'm sure Sheila can elaborate.
I love that notion on the age norms. That's just a huge thing about, in our clinic. So Mission Eye Care has, we've created what's called the Mission Academy.
I love that.
What it is it's a specialty within our office that allows us to kind of offer full scope services where we can charge for special additional testing. We can bring people back for separate exam. And we have, all the equipment that you mentioned to really do a full comprehensive. But I love that notion that you said of really picking off patients that are outside of their age norm.
Yes.
So really anybody is suspicious for myopia until otherwise. So once they cross that 6, 7, 8 years old at 0, up until then we're watching every kid just to see if they're shifting in the minus direction that moves them outside their age norm. So just for you guys to kind of to have us on the same page, 6-year-old should be a plus 75.
Right.
Yep.
So a 6-year-old who's not, I think that's what you're talking about.
That's
is really
exactly what
very
I'm referring
suspicious.
to.
And then we look at risk factors such as family histories. And
yes.
then, the funny thing today, we see kids in the clinic coming through with higher levels of myopia at younger ages with no myopic parents.
Mm-hmm.
So
it's true.
You have to just really screen everybody.
Yep, absolutely. Yeah. So we know that lifestyle is a factor, and
yes.
Behavioral differences, being indoors more, screen time, all these things do play a factor. Tell me each of you, your personal entry point into myopia management. So how did you start practicing myopia management? Was it, and how long ago, if you can kind of remember when that started, Evelyn?
So I think for me, even going to optometry as well, it's with my sister. She was like a -7. And being a -7, She had a retinal tear and everything else. She was already in, back in the day, RGPs, because we thought that was going to be the best option. And now I see my little cousins, and they're all myopic. And I'm like, the moment you started becoming myopic, we already knew you were going that trend.
Writing's on the wall.
Yeah. And so if we can try and prevent that or slow it down in any way, we really should. And that's when I started to really get into it.
Yeah.
Yes.
And from a practice perspective, was it atropine? Was it spectacles? Was it soft contacts? What was your initial, did you have an entry point in that sense?
So I graduated in 2017. And when I graduated, that's when some of the lenses were just coming on the market. And we hadn't learned about it in school at all. Mm-hmm. So this was like, what is this new technology? Let's read on the papers. And once we read the papers, we were like, wait, there's really a possibility that this is going to work. And then when you try it on the patient and you're like, there's something new, try it. And then you see the implications of it and you see that it works. That's when you're like, okay, I have an epiphany and I have a solution that you can now apply to all your patients.
Yeah.
Very cool.
Excellent. How about yourself?
Honestly started during my residency. I had mentors always who did a lot of research in myopia control.
Got you.
In particular, ortho-K, specialty lens design. And then when I was teaching at the school, I spent a couple years teaching at the University of Houston in the contact lens department, obviously. And at that time, Earl Smith was the dean of Houston, and so he is really the kind of godfather that really coined the whole optical defocus theory. That's where all that research went on the primate models. And so I really had, a catapult right into the latest research for several years. And so then coming back to Calgary, it was a no-brainer. We had to bring in all the things that I learned in the schools, partnered with what Andrew's already doing in the clinic. And so, that's kind of how our Myopia Academy came to be, was that merging of the academics in a perfect world. What are people doing with what is realistic in the clinic?
Right.
How do we put all the science into clinical practice?
Right. That's an excellent point. We're going to get into the clinical, how to really build out that program and for success in a minute. But I think what you just said there is so important, is taking what is kind of in the papers and proving we know statistically this works, but how do you actually bring that into clinic and make it functional, and develop the protocols and algorithms and all those kinds of things. So we'll talk a little bit about that. Now, one of the things, we've done lots of episodes on myopia management in the last year or so, okay? And
it's a hot topic.
It is a hot topic, first of all, number one. But number two, it's the reason I keep doing it is because I believe it's very, very important that we need to help our young patients and reduce the progression of myopia. I truly believe that. We practice in our offices as well. But I see that many of our colleagues are a little hesitant. Maybe they have some hurdles or some stumbling blocks along the way. First of all, what do you see as some of the potential stumbling blocks for an optometrist who wants to get into myopia management or is just beginning to? And then what advice would you maybe share to that person who's looking to get into it?
Probably, I would say the biggest maybe initial hurdle and roadblock would be the discussion about fees, setting your fees, setting the clinical protocols. Yeah. Patients or practitioners sometimes have the feeling that patients are really going to be sticker shocked or whatever if you tell them, we're going to do ortho-K, it's going to cost this much money. We're offering extra services, extra link like you do. It's going to cost this much. Although BC now has a billing code for it.
We are the first province to have a billing code.
To BC, and
that's it. One more big shout out to the BC Doctors of Optometry for negotiating that and bringing in an axial length billing code. So thank you.
It helps all the provinces because our province will follow suit.
Yeah.
It's one of those things that really just rises the level for everybody.
Yep.
Totally.
But I do think that, doctors know the science, they know what works, they know that they can do it, but putting the different treatments together into a clinical model that actually is profitable and kind of getting over that hump of the fear of talking about prices with patients and the fear of patients, walking across the street to your competitor if you're charging too much or whatever for those services.
Okay, so what advice do you have for somebody who's stuck on that right now? This is, I guess, kind of going into our practice management discussion that we're going to eventually have. But what do you have? Let's say I'm saying, Sheila, I want to get into it, but I don't know how to charge right, so I'm not doing it because I don't think I'm going to get compensated properly.
I would start off, if that's your position, which is very common, I would start off by partnering with a mentoring clinic that somebody who's already doing
established,
yes. So when they're doing somebody that you're close with, and the other option is using industry. So our industry partners, like Hoya, for example, has created incredible resources just to kind of get a clinic flow or
Right.
what marketing you need to do. So I would reach out to your consultants and your besties in myopia control and just find out what they're doing and what works for them for pricing in your area. And then the bottom line is lay the infrastructure so that everybody in your clinic is doing the same thing.
Right.
Prices are all laid out. It's really easy for people to know what to do. And that, again, it's very clear for patients so that you can really speak confidently when you are having that conversation. Because if you don't know what you're doing,
100%.
how can you get the patient to trust you?
Yes.
You know what I mean?
Absolutely.
I think what Sheila is referring to here is that protocol. So not only are we setting the fee structure, but that your staff are on board and they understand that this is an important endeavor.
Totally.
Yes.
Everybody buys in, then
Totally.
patients are more likely to get that energy back.
Yes.
Absolutely. And to take that a little step further, so obviously staff buy-in. So one of the things that recently I've been trying to, I need to be better at personally is my associates are like saying, what's your, like they want to do it, but they haven't like, when do you do axial length? Like where does that fit in our protocol? Are we doing it on every kid? Are we charging for it? And that's something that when you have that set, now I can it's written like, here you go guys, here's what we do. Not just what I do, here's what we do now together. And so that's something that I'm kind of working through. As much as I've been doing myopia management for years, it's been me doing it. And I just kind of like along the way, I'll just change up what I'm doing. But I need to have it properly documented so everybody's following the exact same.
Right.
So that's something I need to do. Anything else you want to add to that, Evelyn, as far as like, what do you see as some of our colleagues maybe finding it difficult to enter into myopia management?
I think one of the other things is probably they feel a little bit lost. Do I start with one modality or do I start with all modalities?
Right.
Right. And I think the easiest ways, if you're feeling like, where can I start somewhere? Pick at least one thing.
Yeah.
Right. And get good at that one thing. And then, of course, you can expand from there.
Totally.
Yes. You don't want to be jack of all trades and master of none.
Yeah.
I love that.
Yeah.
Start with one. I think that's a great way. That's a great way to get into it. And that's actually, I just by default started with atropine years ago, and then kind of I saw it actually works. Now, what other way can I approach? And I still to this day don't do ortho-K, but I started doing soft multifocal contacts, and then the MyoSmart came out, and then I was all about that. So now I'm slowly trying to get into ortho-K. I'm like pitching it to every patient. Did you know that you could walk around without glasses or contacts? Like, we could do that for you. But this actually takes me to one of the questions I wanted to ask you is with, patients who play sports or active lifestyle. Like, let's get a little bit into clinical conversation here, right? Mm-hmm. So let's say you got a parent and the kid in the exam room and child's myopic, so they need correction. But they play sports and they don't like the glasses on their face when they're playing soccer or something like that. What's your approach in that scenario? How are you talking to the parent and the child?
So are we saying we've decided we want to try to get them to some form of contact lenses?
Yes.
Perhaps.
Well, I assume that makes the most sense. Yeah, let's say he's at -3 and he can't play soccer without some sort of correction. So contacts make sense, right? Mm-hmm. So how are you approaching that? Are you doing ortho-K? Are you doing something else?
So I'm a big proponent of offering the option. So spectacles are the safest option in the market, honestly. We'll have lots to talk about glasses options as well. But there are many, many old studies that have documented time and time again, not only the vision and the myopia control, but the benefit of contact lenses in youth, providing confidence, ability to do extra tests. So there's lots of lifestyle things that can be a benefit. And so I'm always having that conversation just to let them know that it's an option. And then from that point, if there's a bite and they're interested in a contact lens, then I start to look at physical structure. What are you a candidate for? So there are some patients that really would not be a great candidate for a daily disposable approved like myopia control lens because they have too much astigmatism. Mm-hmm. If they have the right amount of astigmatism, like within about up to 2 diopters, then I'm thinking, this could be a really nice ortho-K case because we could get rid of the myopia and the astigmatism in the same time. Yeah, and I personally tend to reach for that as an option over a monthly disposable off-label, just because there's not as much out there in the myopia control literature. Right. So I'll look at physical structure and what are you candidate for? What can you actually wear, and then what makes sense for your lifestyles? Is your sport swimming? That's a no-brainer. We try to stay away from soft lenses all the time. We go with ortho-K. Do all their whole entire family wears soft lenses and they're spherical -5 or something, or -3 per patient. That's a great candidate for that on-label, daily disposable soft. That's approved for me.
Right. Anything to add to that? Let me give you another scenario. Let's say
we're going to be pretty aligned.
We are very aligned on this.
What about so this happens in our offices, I'm sure, many times, right? Kids play sports. The idea, so the parent is maybe a little hesitant about contact. So I'll pitch ortho-K, they don't want it. So then the other combination that I'll often do is they'll be in a MyoSmart most of the time, and then I'll give them just a normal daily disposable soft contact lens for the couple hours, the 6 hours a week or whatever that they're playing sports. Is that something that you guys will do, that kind of a combination, or would you rather just put them into a soft contact lens that they're wearing all day long?
No, for every one of my patients, you definitely need to have a pair of glasses, because there will be moments where you need that. And then you will definitely also need your soft contact lenses if you're going that route. Yeah. But I always start off with, the first time I'm going to be prescribing, it's going to start off with a pair of glasses, and if that's going to be MyoSmart, that's MyoSmart. Yeah. And then if they say, and I see them back usually about 6 weeks, to just check in and see how they're doing. They're a -5 for the first time. I want to make sure they're seeing well. Yeah. Right? And at that 6 week mark, that's usually when I'm saying, hey, so I also know you play basketball, and now that I know you can see well and you now appreciate this world, do you want it to make it so that you can see your periphery a little bit more too? And then we engage in the contact lens. But now they've bought into the glasses and they know that it works. Then we're going to offer another solution and they can use the combo to their liking.
Mm-hmm. And I love what you do, what you mentioned about kind of using the sports part-time as kind of an in for contacts, where they're using their myopia control glasses more than 70% of the time. Yep. You know, the literature shows that we have to be wearing whatever correction at least that amount of time for it to be effective. And I think that's pretty much across most studies. Yes. And so, you know, using those kids that really just are kind of hesitant, parents are unsure, well, here, why don't you just try a daily disposable that's just regular for that couple hours a week for the sports? So I do that. And I'll use that as an in for contacts. Yep. But then what I see happening most of the time is they love their contacts. And
they'll convert.
I see.
Yes.
Yeah.
Yes.
And then the most optimal solution will say, you know, if it was my child in a perfect world, if we can have things at the level that we want, myopia control on all your devices. So then we move them from that regular part-time into you do what you want. You put on contacts, glasses, you're getting myopia control in both.
Right. Yes. Right.
So it's a great tip. I think that's a great practice management tip, is to be able to kind of convert those ones that are on the fence, use their sport and activity like you're doing as well, and say, you know what, just here you go. And then they're going to have their mind blown when they can see their periphery for basketball.
Yes. Yep.
It's so much better.
It's so much better.
Yeah. Absolutely. So sticking with clinical, and you know, we've used the term combo there just in that sense of glasses and contacts, but you also, you mentioned, let's say, Evelyn, there's a patient who's coming in and they're highly myopic or they're progressing really quickly. The other way we use the term combo right now is combo treatment in the terms of like adding atropine to something else, whether it's Ortho-K or soft lenses or the glasses. Have you done a little bit of that? And where would you sort of draw the line on, give me an example of a patient where you'd be like, this is a person that I need to put two forms of therapy into it?
Yeah, and so some of that is also when you see the genetics and you know they're clearly high risk. Both parents are like going to be like a -15, right? And you look back at that age norm and you're like, well, is it going to be within where it's supposed to be? And often if you look at it and you're like, okay, well, it seems like its axial length is changing, but also the diopter is changing really quickly as well, then I'm going to be like, hey, look, this option 1 gave me this much slowing down, right? And then if we added this, is it going to give me a more effect? And I do think that combination is very, very important. May that be in the combination of contacts and, like, say, MyoSmart, or glasses and atropine. Yeah.
Oh, that's great. So how about for yourself, Sheila? Anything that a different approach
there?
So
the literature is very mixed on combination therapy when it comes to adjunct. So adding atropine to one of our optical therapies. There are very few studies. Some show that it helps, some show that it doesn't. But what we kind of do is very similar to you, is first start with one thing, see how far that gets us. Yes. And then, you know, if it's not giving the desired result, meaning that the patient is still growing faster than a normative growth rate, you got to do something, especially on those long eyes. Like if you have an eyeball that's already 26 millimeters, those are those higher risk ones that we want to maybe go for the combination. And in some cases, if they're really small, we'll add combination a little earlier. Yes. So say if they're, you know, maybe we start with 3 to 6 months with just Ortho-K, see how far that gets us, and be very quick to add the atropine if they're small and still progressing quickly. That's that through to fast growth. Yeah. But yeah, I do think that we need a little more time with the literature, and I think there'll be better guidelines of when it's appropriate and how effective is it. Because in theory, you know, intuitively, it seems like the combination would be helpful. I see combination therapy being helpful.
I do too.
Patients. Yeah. That being said, there are some reports in some patients that that's just not the case. And so, so you think 2 therapies are better than 1? Not always. So there will be more hopefully study on that.
On that note, is there anything that shows that it's detrimental, or it's just not necessarily? It's not necessarily more beneficial.
I've never seen anything that shows that it's detrimental. But what can be detrimental is if we add adjunct therapy and we're not mindful of symptoms, for example.
Yes.
It can be detrimental if we go ahead and start atropine and then a patient stops at cold turkey.
Right.
Yes.
So if they're taking it, the new studies are showing again that even in the lower concentrations, atropine can rebound if we stop at cold turkey. So there are ways. Yeah, and then of course the cost of it, there's side effects for it. So in that note, I suppose detrimental. I think those are negatives.
Yeah.
But overall, when used as directed, the therapies work really, really well.
Yeah. Correct. Okay, great. So when we're talking about prescribing spectacle lenses, the MyoSmart, for example, Hoya has the standard MyoSmart lens, which of course works really well as far as slowing down the progression of myopia. But they also have the Chameleon, which is the photochromic. Where do you see the photochromic version of MyoSmart falling into your treatment plan?
So it's actually something that I recommend for all of my patients to start. And the reason for that is just because we know our kids are going to be outside. In BC, we have great outdoors, so we want to encourage them to be outdoors. So it's always the first thing I say. They can have the option to choose otherwise. But I feel like if I don't actually talk about it and then they're offered afterwards, then they usually come back with more questions.
So interesting. So if you're prescribing MyoSmart, you're almost automatically, it's the Chameleon, it's the photochromic first.
My opticians know right away.
Got it.
That's the first thing we talk about.
Makes sense.
Then the next thing we talk about is, well, if you are like, I don't really want that change in the coloration, then we go for our next option.
Got it.
Yeah.
How about yourself? Any difference in that?
I would say it's very similar.
Yeah. Actually, to be honest with you, it's silly for me to say this, but I didn't think about approaching it that way. So I will usually, I'm prescribing MyoSmart, but I'll say, oh, does your kid spend a lot of time outdoors? We also have the option for photochromic, but I should just start with photochromic, and if you don't want it, then let me know.
Some don't want it, honestly. There are families that don't, but definitely important to make sure that they know it's an option.
Yeah, I think I would just say when I do recommend it, most people they understand the value in it, most parents, and they'll usually choose to get it. But it's just a matter of me making my default like you're doing, and I think is the better approach.
Yeah.
Speaking of which, one thing we definitely want to talk about is that conversation, that communication with the parent and the child in the exam room, right? So, Evelyn, I know you wanted to share some insights on that with me, and I think that's also one of the potential stumbling blocks for some of our colleagues who are getting into myopia management. It's like, I don't really know how to bring it up in the exam room. So how do you talk to parents and the kids, and how do you get the buy-in that we need for this?
I think there's two things that you have to think about. One is whether or not you get the child by themselves initially in the exam room versus if you get the child and the parent in the exam room. Because they're two actually different exams. And when I have the child by themselves, usually they're a little bit older, we're having a constructive conversation, and at the end of it, usually I'm saying, hey, look, here's my recommendations, including, let's say, screen time, including how I want you to wear your glasses or your contact lenses. And when we step out of the exam room and I present that back to the parents, then I often say, and your child is going to tell you exactly what I just said. So the repetition
I like that.
And the fact that the child is going to tell your parents exactly what their step plan is.
Yeah.
And then I'll add in if they forget something. But immediately the parent is like, oh wait, that just came out of my child's mouth.
That's awesome.
That it's 2 hours a day
Yeah.
of screen time recreationally, maximum. And then once they said it, the child actually is like, oh, I feel like I have to.
Now you're committed.
Yeah, I'm committed.
I just spread myself over.
Yeah, exactly.
I love that. That's awesome. That's very smart. Some psychological warfare going on there. I like that. So you get the kid to repeat it to the parent, and that way the child, repetition, they're going to remember it more. But now they've said it out loud. They're kind of committed to it.
Yes.
And the parent's impressed that their child is saying all of these things to them as well. So everybody's buying in more. That's awesome. I love that.
Absolutely. Versus where the parent and the child is in the room, it's a little bit of a different conversation. It's a little bit more like, okay, this is what your lifestyle is. What is mom in agreement with that? And then we'll have that conversation together and collaboratively come up with those options. I personally prefer the first option because a lot of times it's more natural and the child is by themselves. They're really becoming more independent. So to promote that, I think it's a lot easier to be like, hey, take hold of what you care for. And if vision is part of that, you're going to naturally want to make that decision.
That's great. Anything you want to add to that, Sheila, as far as communication?
No, it's funny. I actually recently was listening to a podcast, and it was talking about so communication is drilled into us over and over and over in healthcare, right? So we need to communicate. We need to have clear communication where we sign our forms, make sure everybody understands everything. But one of the things that they mentioned in this podcast was comprehension is more important than communication, and that you can speak and do all these things, but to your point, you really need to kind of take a second and understand where your patient's at. I think that goes along the lines of, have you guys heard of empathetic care in healthcare?
Yeah.
Empathetic care, it's really big, and especially like in the ER, for example. And what that means, there's two prongs of it. One is empathy, purely. So you're actually practicing from an empathetic approach, taking time to talk to patients, adds to quality of life. But empathetic care also means that you're choosing strategies that are actually doable for a patient, and you're choosing ways to talk with them that they can actually understand. So I think that when it comes to communication, we are at the kind of point where these clinics are, you know, kind of the standard of care. And so when it comes to communication, it's that higher level, I think, where we're not only communicating clearly, making sure patients comprehend what we're saying, and that they are on the same page about, well, yes, I can do that treatment. That's something that fits in my lifestyle. I can afford that. We're all bought in.
Yeah.
You know?
Yeah.
Because you can't tell somebody that you want them to do something if they physically just can't do it.
Absolutely. That makes sense. Never thought of empathy in that regard, but that makes total sense. Like, it's more empathetic if you're kind of meeting the patient where they are to bring them treatments that are actually doable and they can act out versus throwing something at them where they're like, well, I don't even know what this means. Like, how would I?
And you know, that is like the key to compliance. And when it comes to efficacy, safety and compliance are the two, I would argue, number one things in any medical, but definitely the myopia clinic when we're using pharmaceuticals, medical devices like contact lenses. Compliance and safety and, you know, empathetic care, we have to be talking to patients and meeting them where they're at.
Yeah.
So I love that you said that.
That's amazing.
You and I are comprehending each other.
Yes, we are speaking empathetically to one another. All three of us. Talk about compliance. Is there more you want to say on compliance? I know that's something that you brought up that I feel like is obviously for efficacy that makes total sense. If I'm not doing the treatment, if I'm not compliant, there's going to be no efficacy.
You know, and it's a huge, you know, anytime I have the opportunity, you know, I've been around you long enough that compliance and safety, you know, it's a huge responsibility. And so minding our safety, crossing our T's, dotting our I's when it comes to anything we're doing with kids. And that does come down to clear communication. So that's all I want to say about that.
Got it. Sorry, I wasn't sure. I just wanted to make sure that we because I know you mentioned compliance. I wasn't sure if there's more you want to add. Okay, what other, so in that regard, practice management wise, any other practice management tips we want to share with our colleagues out there who are listening to this, who want to, maybe they're already doing myopia management, but they want to improve. They want their practice to do better. They want to make more money. They want to help more patients. One piece of advice that you might want to share on the practice management side of things.
I can only say that it's evolving on a daily basis in terms of the technologies that are coming out. You have to stay relevant. And maybe I'm just going to put a plug in. You just got to be with the association. They're going to tell you all the different resources. They're going to have a lot of the industry events that are going to be out there for you to get that firsthand information. But never stop learning.
Got it. How about yourself, Sheila? That's it.
I can't top that. Never stop learning.
Never stop learning. Okay, I want to zoom out for a second. We've been talking obviously in the clinic, in the practice, in front of the patient. But Evelyn, you have some. I'd like you to kind of share. You have some information or some trends that you've been seeing and you've been involved with that you want to share on myopia management more on a global scale. What do you have to share with us about what you've seen?
So just based off of some of the research and some of the background and what I've been doing in China as well, that's where a lot of the studies have come out initially just because there's such a large database, right? We are seeing that it used to be very focused and very heavy on ortho-K, but with the new technologies that are coming out, the shift from ortho-K now in Asian patients to, let's say, spectacle options, may that be MyoSmart or other alternatives, it is definitely picking up. And when we were last chatting with some of the researchers in China, they were saying that they're seeing that uptake happen like this. Yeah.
So it's not just here. You have something you want to add to that, by the way?
No.
So I wanted to say on that, actually, on that note, we are really fortunate here in Canada that we have access to the spectacle lens option. Like, basically, there's very few other countries in the world who have it. Even our neighbors to the south of us, who generally have everything, don't have this, right? And
we should be very proud of this.
We should be, but no, we should take advantage of it. We should be proud. We should own it. And people could look at us already, look to Canada and say, wow, you guys have spectacle lens options. I wish I had that. We have something at our disposal that people are envious of. I think we should all, use it and take advantage of it and help our patients, take the opportunity to help our young patients and give them a better future with with these treatment options that so many other people in the world don't have. So that's my little 2 cents on that little bit. Seeing that the trend, obviously in Asia, where we know a lot of this studies come from, the data comes from, because they have the larger sample sizes and everything to run these tests. If you're seeing those trends over there, it makes sense that these technologies work and they're easy to implement, right? So I think the glasses, to me, I've asked you guys this question a couple of times as far as like an entry point into myopia management. Mine was atropine, as I've mentioned, but I think right now today, the glasses is like the easiest, and you said it's the safest, right? It's the easiest to implement. So a patient, a -2 or -1 patient even is sitting in front of you, you can do the simplest thing, take them out of their standard glasses and put them into MyoSmart, and boom, not only have you corrected their vision, you've already started myopia management, right? Like it's that easy. So I wanted to just kind of say all of that to encourage our colleagues out there to kind of get into it a little more. Whether you're wanting to do the spectacle lens option or the contact lens option, ultimately the point of this conversation is to
start somewhere
and get into it. Yeah. So before we wrap up, any other final words of wisdom that you'd like to share?
Start where you are, like you said. I mean, there's so many resources. It's actually really amazing the amount of CE that's available in the realm of myopia control. I mean, it's all over the podcast. There are meetings dedicated just to myopia control. And really, to build off of, I think one of you was just saying, to not fall behind in the technology is what you were talking about. Stay relevant. I mean, 100% of the schools of optometry teach this in the curriculum. It's not really an option anymore.
Right.
It's the standard of care.
Right.
So that would be the final message I would leave, in that, if we're following what our governing bodies expect of us as optometrists and vision care providers, that is to provide myopia control and myopia management services for our patients, or know where to refer when you identify a patient that falls in that category.
Great note. Yep. That's a great note. Evelyn, anything else you want to share?
I'll piggyback a little bit on that, and I'll specifically say for those who are going to be graduating and they feel like that they didn't get enough of this in their curriculum, just get started. Ask, right? There are people that have already graduated and are getting into this. Ask them what those lenses are, right? Talk about myopia management with your peers, with your mentors, so that you can start saying, look, I don't know a lot about it, but let me start dabbling in it. And I think that's the best way to get started, because academia will give us this much, but you still have this much to learn. Yeah,
and as we were saying earlier, taking what you've learned in school and implementing it in practice is a thing on its own, right? It's not like you can just take that and boom, you're doing it. You have to think about how does this integrate into your practice, into your day-to-day, your protocols and algorithms.
You just made me think about, and I don't know if anyone's doing this yet, but I wonder if we'll start to see myopia management residencies.
Oh, interesting.
Do you know what I mean?
Yeah.
Because right now it's partnered with ocular disease, primary care, contact
There's
lens.
really not a space for that right
there's
now.
a lot of contact lens residencies that are strong in myopia control, but I just had that idea.
Yeah.
So
maybe you can start one.
We'll see.
Go talk to Debbie Jones at Waterloo. I feel like she'll probably be on that.
Absolutely.
She'll probably be on that one. Yep. Okay. Well, thank you guys. I really appreciate you coming on to chat about this and sharing your expertise. Dr. Evelyn Lo and Dr. Sheila Morrison, thank you guys very much. And by the way, if you're listening, I would want to make one quick recommendation. Go to YouTube and flip this on and see the amazing the combo that Sheila has matching her glasses to her shirt. That's style right there.
I did a special for the podcast.
It's style. Okay, so please check that out. And it's not like blue and blue or black and black. Okay, what is this color? It's like a bright peach.
2 shades coral, reddish, corally.
Yeah, like that's not everybody can pull that off. So. Go check that out and go give Sheila some props for the style. All right. Thank you, everybody, for watching and listening to the 2020 podcast, Canada's #1 optometry podcast. I'll see you guys in the next episode.